So, hi everyone. Welcome to this session. We're super happy to have you again on this WHO and TechNet webinar session. Welcome to this session on the importance of diphtheria, tetanus, and pertussis DTP containing vaccine boosters. You can listen to this session in English and in French. To do so, please click the globe icon and select the language in which you'd like to listen to this session. We'd be happy to know who's with us today. I see some people already introduced themselves, but just let us know where you're from and your name. That would be great for us to see, all the participants from all those countries. If you have any question during the presentation, please use the Q&A box. The Q&A box is available at the bottom of your Zoom window as well. You can ask your questions at any time, and the panelists will answer your questions during the Q&A session. Finally, this session is recorded as we are used to, and we'll share with you probably next week the links to the video in English and French, as well as the slides in English and French. That's it for me. So I hope you'll enjoy this session, and I'll give the floor to Stephanie. Stephanie, the floor is yours.
Thank you, Alex. Hello and welcome, everyone. I see we have participants from a really diverse set of countries already on the line, which is always exciting. Some familiar faces, some familiar names, some new names. I will also just put the links in the chat to PDFs of the presentations in both English and French. So they're available there also if you want to follow along at your own pace. But as Alex said, you can toggle between the two screens for English and French versions of this presentation. We have a lot to cover today. We do have 90 minutes, so hopefully that leaves sufficient time for Q&A and also for discussion. We'll leave all of that until the end of the session, but you can ask your questions at any time, or you can save them to the end if you wish. We also have an option for you to raise your hand and we can unmute you so that you can actually provide an intervention or a discussion vocally as well. So we'll save that till the end of the presentation. I'll get started because we have 4 sections to cover today. You can switch to the next slide, please. So today's presentation will be divided into 4 subsections. I'm going to start us off and then hand it over to colleagues from UNICEF, Gavi, and Supply Division. So my name is Stephanie Schendale. For those of you who don't know me, I'm at WHO HQ in Geneva in the EPI team on life course and integration specifically. We also have UNICEF colleagues, Nicholas Danielson, and UNICEF Supply Division colleagues, Nuria Amek, on the call today. And we have Amina Ismail from Gavi. I'll let each of them give a little bit of a more thorough introduction as they start their sections on their own as we go through this. Maybe next slide, please. So just a quick background, DTP is our benchmarker for immunization programs. We talk about DTP all the time, DTP1 coverage to mark 0 dose, DTP3 coverage to mark proxy indicators for how immunization program performance is going. And these vaccines have been around for so long that actually sometimes it's important to kind of step back and remember which diseases they're protecting us against. Some of these diseases we don't see that often anymore. Some of them are, making more of a resurgence lately, and some are always there, kind of in the background. But we kind of take it for granted as these vaccines have been around for so long. So, just a real quick recap on what DTP really is. So we're talking about 3 different diseases, 3 different bacterial diseases, diphtheria, tetanus, and pertussis. All 3 of them are bacteria, and they all cause toxins. The toxins are the part that actually does the damage in all 3 of these cases. Diphtheria and tetanus, still in the absence of treatment, have pretty high case fatality rates, although we do see them luckily less than we used to before vaccination. And pertussis is still endemic in all countries, And before routine immunization became the norm against pertussis, it actually killed twice as many children as measles and polio combined. Luckily, that's not the case anymore, but even in countries with high vaccination coverage, pertussis is still an important cause of morbidity and mortality, particularly in infants worldwide. In 2019, or as of 2019 estimates, the three of these diseases combined caused an estimated 167,000 deaths and a loss of almost 15 million DALYs. Over 80% of those were due to pertussis. The next chunk responsible is tetanus, and a smaller amount, luckily, due to diphtheria. And all three of these are obviously vaccine preventable. But the immunity from the 3-dose primary series alone, which is still the norm and the only vaccination series in a lot of countries, wanes to non-protective levels after time for all three of these diseases. So this is why we need boosters. Next slide, please. So just maybe a quicker deep dive on each of these three before we move on. So the WHO recommendations on diphtheria, just to recap, the recommendation is a 3-dose primary series, which is very highly effective. However, the protection against diphtheria does wane, and therefore boosters are needed to ensure continued protection. We can see evidence of this waning immunity demonstrated in the recent diphtheria outbreaks. As everyone on this call is familiar with, there were significant numbers of outbreaks of diphtheria reported last year in particular. In a lot of countries in the African region, we saw really, really high cases. You can see the epi curve there from midway through earlier this year. And across, for example, 7 of these countries in this particular analysis, you can actually see that the cases are majority in the sort of older children, adolescent range. And they also did an analysis, and 24% of these cases were fully vaccinated with the primary series. So this does indicate that waning immunity might be a contributor here, and further highlighting for the need for booster doses. Next slide, please. So the WHO recommendations on tetanus are actually aligned with the ones on diphtheria. 3-dose primary series is highly effective, but wanes pretty rapidly after 3 to 5 years. Therefore, boosters are required to ensure sustained high seroprotection. A full 6-dose regimen of tetanus vaccination by adolescents is actually expected to protect for the long run through adulthood, and we'll talk about a little bit more about that later on as well. And 6 doses is also contributing to equity by ensuring both girls, boys, men, and women are protected as well. A lot of the efforts and vaccination efforts for older people for tetanus is concentrated in females of reproductive age, because we know that maternal and neonatal tetanus is still a large priority in many countries. But this means that there's a large chunk of the population that isn't necessarily getting addressed with interventions for booster doses of tetanus later on. So ensuring that this is all in the routine program to reach all individuals is an important marker of an equitable vaccination program. Next slide, please. And finally, the WHO recommendations on pertussis. So as I said, pertussis is still endemic in all countries. The true burden is difficult to assess because there's suboptimal surveillance and reporting almost across the board. You can see in this curve in the bottom corner, if you look at pertussis incidents reported over recent years, there was a significant drop during the pandemic period, because of surveillance issues and also because of the COVID-19 protective measures that actually prevented a lot of the respiratory illnesses that we normally see. But even though we don't have 2024 data yet represented here, we can see that even in 2023, we're back up again to pre-pandemic levels, and we can expect that a similar pattern will emerge for 2024 data. And so high coverage for tetanus vaccination is primarily aimed at protecting infants and young children, where the morbidity and mortality for this disease is the greatest. And we know that 3 doses plus a 2IL booster will considerably reduce severe disease in children up to the under 5-year age range. Some programs in some countries do include boosters for pertussis for older age groups, but this isn't meant to be a strategy as a means of controlling pertussis in infants, but it has been shown to decrease incidence in older ages. And that we also know that there's even more rapid waning of immunity, and possibly reduced impact of transmission with the acellular vaccine relative to the whole cell vaccine. So the recommendation is that countries that are currently using whole cell should keep using whole cell and not switch to AP. But all Gavi-supported vaccines include the whole cell. So for the audiences on this call, this may be less of a concern. And supply division colleagues will talk later on about what supply vaccine products are available under this particular Gavi-supported program. Next slide, please. So just to consolidate the recommendations across all 3 diseases, this is the WHO recommended 6-dose schedule for DTP-containing vaccine boosters. So as I said, the recommendation is 3-dose primary series for all 3 vaccines, plus 3 boosters for tetanus, 3 boosters for diphtheria, and at least 1 booster for pertussis. Because these vaccines are all given together in combination vaccines, the WHO recommendations are therefore programmatically aligned to ensure that these boosters can be provided as combinations for the booster doses as well. So we have the 3-dose series recommended in the first year of life, starting from as early as 6 weeks, containing all 3 of these. In most countries nowadays, this is given as either a penta or a hexa combination. The first booster is recommended to be given in the 2nd year of life, so in between 12 and 23 months. And again, this should contain all 3 of these antigens. So this could come in the form of a DTP booster, or a 4th dose of penta, or a 4th dose of hexa, if that makes programmatic sense in the country and it's chosen that way. The second booster is recommended in the 4 to 7 year range. And this one should have a tetanus and diphtheria for sure. And then it can be given with or without pertussis, depending on the decision made in country based on epidemiology and other factors. And this could be a TD or a DT, because TD, T with reduced diphtheria, is indicated from above 4 years of age. DT with the pediatric diphtheria component is still licensed to be given up till 7. So you have some flexibility with this middle booster, whether you want to give the reduced or the full diphtheria component. The 3rd booster is recommended between 9 to 15 years old. So again, this is 1 dose of tetanus, 1 dose of diphtheria, and then with or without pertussis, depending on the decision in country. But this should be the reduced dose of diphtheria, absolutely. And so that could be TD, or it could be a Tdap product if that's what the country chooses. Next slide, please. Okay, so the global status of DTP-containing vaccine booster introductions. Next slide, please. So we do have a poll question now. Alex, I don't know if you can activate the poll, but as of 2023, how many of the world's children and adolescents eligible for DTP boosters still did not have access to them? I'd like to know what people think about the prevalence of boosters as of 2023. I see people are still answering, so we'll give it a few more minutes. Okay, responses are slowing down, so maybe let's end the poll now. Can see a variety of responses here. I don't know if you guys can see the variety of responses. It's on my screen, but I don't know if it's on everyone's screen. We can see it, it's kind of across the board here. A lot. Most popular answer was 100 million. Second most popular answer was 500 million, and then followed by 1.2 and then 500,000. Okay, maybe we go to the next slide for the answer. The answer is 1.2 billion. 1.2 billion of the children and adolescents under 14 years old, so 32% of the under 14 years children and adolescents in the world live in countries that do not offer a single routine booster. So all of these children are getting the 3-dose series, but all of them are most certainly having waning immunity after a number of years against these 3 diseases. Next slide, please. And so here you can see what the global distribution of these booster introductions is. This is JRF data, so we all know that there are some caveats that come with JRF data. This is country reported data. This doesn't show us coverage. This just shows introduction. So it just shows the countries that have these boosters in their routine schedule. And you can see that clearly the African region is really lagging behind in these booster introductions. Most of the countries in Afro still have no boosters at all, although some of them do have 1 or 2 or even 3, as in the case of South Africa. We also still have some patches in the Middle East and Southeast Asia that have yet to introduce all the boosters. So it's still distributed around, but you can definitely see that there are pockets where attention is needed. Next slide, please. So I'm going to hand over to Nicholas for this next section, but maybe just before I hand it over to him, we have one more poll question. So true or false? Programs must introduce booster doses in order. So they have to start with the 2nd year of life, then the introduction of the childhood, and then the adolescent. You see the answers are still coming through, so we'll give 2 more minutes. Okay, the polls are slowing down, so maybe we'll show the results. And it looks like we have about half and half in responses here, a little bit more answered myth, but almost half answered truth. So maybe if we go to the next slide to see the answer, click one more. So this is a myth. It's not necessary that programs introduce them in order. Any booster is helpful. All boosters are helpful at any order that they come. So I'll hand it over to Nicholas now to explain a little bit more about the opportunities for programmatic integration of these boosters with other touch points along the life course. Over to you, Nicholas.
Thank you very much, Stephanie. Confirm that you can hear me. Good. Okay. Thank you. So, first of all, I would like to recognize that we just passed 100 participants, which is great. And I saw someone connecting from Samoa, which I think is admirable because it should be in the middle of the night in Samoa. So we have at this point agreed that the recommendation is for children to receive 3 DTP-containing boosters before they enter adult life. And you see them here on the slide, and Stephanie also showed them to you. And the booster 1 is recommended for the 2nd year of life to 1-year-old children, and booster 2 to the age group 4 to 7 years old, which is really around the start of school or preschool engagement. And booster 3 is for the 9 to 15 years age group. At the bottom of this slide, you see a number of publications that are important because they talk about the different opportunities to integrate the delivery of DTP-containing booster doses into preventive primary health care programs. And you will have links to these resources. Let's go to the next slide. So the second year of life booster, the first DTP-containing booster, so that is recommended to be given at least 6 months after the last primary series dose. And in most countries, we are concerned with the primary series is given as pentavalent vaccine. And sometimes the primary series is delayed, and that's why we have this 6 months recommendation. This first booster should have a full dose of diphtheria vaccine. You have heard that we have talked about reduced dose of diphtheria vaccine or full dose of diphtheria vaccine. The first booster is recommended to have a full dose of diphtheria vaccine and also to contain the pertussis component. And the pertussis component can be whole cell pertussis or acellular pertussis. So there are several options for this first booster. One option is to give it as a fourth dose of pentavalent vaccine, which means that you have the whole cell pertussis in the combination vaccines and also the full dose of diphtheria. This is a pragmatic option as it doesn't involve introducing a new vaccine into the national schedule. And it can be seen as worth paying that small premium for using over a less expensive vaccine like DTP, because you will have fewer vaccines in your supply chain and fewer instructions on how to give the vaccines. Countries that are thinking of replacing pentavalent vaccine or pentavalent vaccine and IPV with the new hexavalent vaccine. And I realize that we haven't really mentioned what this new hexavalent vaccine is, but this is a new, recently pre-qualified hexavalent vaccine that has a whole cell pertussis component in it. So they can consider to, as Stephanie also said, to give the first dose of the DTP booster as a dose of hexavalent vaccine. So then the children would also get a dose of HIB, a dose of IPV in the same combination vaccine and a dose of hepatitis B. And you can no, we should go to the next slide, please. So then we move over to the second booster dose, the one recommended for 47 years older. And this is the dose that the fewest countries have in their schedule. And the age range means that it coincides with the enrollment in school in many countries. And today's school enrollment is already very high in most countries and continues to increase. And it's actually rare to find gender inequalities in primary school enrollment today, which is different from secondary school enrollment. So establishing a contact point, a vaccination opportunity around school start, and maybe even a vaccination status checkup at school start is an important opportunity that can be introduced at the same time as you introduce the second DTP booster. And the second DTP booster can be given, also as Stephanie said, either with a vaccine that has a reduced dose of diphtheria, and then normally that would be the small d vaccine, the same vaccine that is used for women during antenatal care, or it can be with a vaccine that has a full dose of diphtheria. This opportunity to introduce a vaccination status checkup at school start and an opportunity to catch up vaccination is maybe particularly important apart from the DT booster with measles. And that is because good measles control and in the end, measles eradication is dependent on extremely high vaccination coverage. So you really want to chase every unvaccinated child you can find. And having a school checkup and a catch-up opportunity for measles vaccination can actually reduce the need or the frequency of having follow-up vaccination campaigns for measles. Next slide, please. So, and the last age group, the 9 to 15 years old, coincides with the delivery of HPV vaccine in many countries. And a large number of countries have by now introduced HPV vaccine in the low-income country group, particularly the countries that have support from Gavi. And within the next 5 years or so, we expect, if not all, most Gavi-supported countries to have introduced HPV. And the timing of the third dose of DTP booster has been planned to be delivered together with HPV vaccine. And that means not giving the vaccine both to boys and girls. I think that's an important point. It's not just a vaccine for girls, it's also a vaccine for boys. And for girls, it is of course important because within the next 10 years or so from that contact point, many of them will have their first pregnancy and give birth to a child, and that third DTP booster dose will help reduce the risk of neonatal tetanus in many countries. But it's also very important for boys because in many countries, low-income countries, boys and men are at increased risk of tetanus for many reasons. Around 4 out of 5 tetanus cases are among men and boys, and that has to do with the kind of work they do, how they exposure, and also because they don't have the opportunity that women have to get TD vaccination during pregnancy. And then we move to the next slide. And that's the TD booster doses that you are all very familiar with, that have been given for several decades now to control maternal and neonatal tetanus. So that you want to give all pregnant women tetanus vaccination, and a few years back it was changed to tetanus diphtheria vaccination with the small d, the reduced dose of tetanus. And if and when the TD booster doses are introduced at second year of life, 4 to 7 years of age, and 9 to 15 years of age, there is an opportunity to reduce the number of doses given to pregnant women, given that you have proper documentation of those doses. Because the recommendation is that when a woman has received 6 doses of DTP-containing vaccine, they are protected for maternal and neonatal tetanus. But of course, that's very dependent on having reliable documentation of doses, because this is a scenario where you want to be more safe than sorry. And if you lack documentation of booster doses and the 3 primary doses, you should always take the opportunity to vaccinate pregnant women. Next slide. I think that's the last for me. Thank you.
Great. Well, over to Amina for the next section.
you so much, Stephanie and team. I'll quickly go through the Gavi support on the eligibility and application process. Next slide. This slide tries to show the status of the DTP boosters in the countries that are reporting through the joint reporting form. And as you note on the extreme left of this table, which was also alluded to in the earlier slide, which had a map showing the countries that have not introduced DTP boosters. And aligning this with the transition status of these countries, a lot of countries which have no DTP boosters are still under the initial self-financing transition stage for Gavi support. And even those that have some kind of booster may not align with the ages that have been provided in the latest WHO recommendation. Next slide. The Gavi support for the countries that are eligible apply in different conditions, but in this particular support, the countries should align to the Gavi product menu and can either introduce a single booster or have a combination of the boosters together, depending on the country's specific parameters and peculiarities based on the immunization schedule. And there is an opportunity for the Gavi IRC review, which is open, and countries can take advantage of the 3 windows available to align and have their applications through to support their DTP boosters applications. Next slide. In terms of support, we have different types of support for DTP boosters. And these are well explained in the Gavi vaccine funding guidelines, which is a public document. You can always go back and get details of each of these. But the first option is on the vaccine dose procurement and associated supplies. Under current co-financing principles for the second year of life booster, we have the DTP, pentavalent or hexavalent, has already been explained. The 3 will be eligible for this category of support. And then for the TD specific support recommended for the second and third boosters, they will not be eligible for this support so long as the price remains equal or below the 0.2 USD per dose, which is the minimum country co-financing based on the current Gavi policy. There is also the vaccine introduction grant and Gavi-eligible countries introducing DTP-containing boosters, whichever formulation, will have a one-time VIG for each new booster. Countries that currently have a booster program may not be eligible for this support if they already have the touch point, except for those that are deciding to switch from either the DTP to either pentavalent or hexavalent in their second year of life. Then they'll be accessing the VIG and the switch support. We also have the health system strengthening support, which is available for countries, and countries can decide to use their HSS grants within the existing ceilings to complement the funds provided under VIG, and also support sustained implementation of the DTP boosters program, of course, after accounting for the other programmatic priorities. Allowable HSS support is detailed in the Gavi program funding guidelines, which you can access and obtain more details on how you can access this support. And countries are encouraged to explore other complementary funding, of course, at country level through domestic funding to strengthen the contacts beyond the first year of life. And finally, we have the TCA from in-country regional global partners that should support the planning and implementation of the DTP boosters program as may be available. Countries are also encouraged to contact their Gavi senior country manager for more details in terms of the TCA and TA support for this. Next slide. As mentioned, the VIGs will be different based on the country's transition phase. For the initial self-financing countries, they will be able to access $0.8 per child per infant in the birth cohort, or a lump sum of 100,000. For preparatory transition, they will access $0.7 per infant or 100,000, whichever is higher. And for the accelerated transition, $0.6 per infant or a lump sum of 100,000, whichever is higher. So depending on what status, transition the country is, they can access these funds to be able to start off the touch point. Really, this is catalytic funding, and we are aware that this may not be enough to continuously support the new platforms, especially those that are not existing. And that's why there's the leeway to also link with HSS or any other in-country available funding to be able to sustain the touch points that may not already be existing at country level. Next. This is my last slide, but I just wanted to share key priorities for 2024-2025, and basically to mention that there is a global DTP working group that monitors and provides guidance on DTP boosters, and we hope that will be able to enhance or accelerate development of guidance materials, basically communication and advocacy materials, and also as NITAG toolkits that would provide support to decision making at country level, and also implementation guidance and training. On provision of TA, we hope to consolidate existing capacities on modeling and cost of illness tools that can enhance justification and rationale at country level to be able to present to the NITAGs and other bodies that would be able to support the country decision making, and also planning and application support for TCA. We have an ongoing learning agenda, basically understanding what is going on in countries that already have the touch points for either of the DTP boosters. And we hope also to initiate case studies that would help support evidence generation for program implementation. Additionally, we hope to advocate for community of practice for second year of life vaccinations and other contact points to really enhance knowledge sharing across the different parties and countries to ease the capacities that countries can be able to borrow from and implement the different DTP boosters. And finally, we hope also to explore intersection with HPV program, as was mentioned by Nicholas. We are able to see what countries are doing on the HPV program and the opportunities that probably are low-lying fruits that countries can quickly grab and add the DTP booster that is aligning with the HPV program. It may not be as easy as I'm saying, but it is an opportunity that countries can leverage, especially those that are in the pipeline of introducing the HPV vaccine, and also the child and adolescent health platforms that exist at the different levels. I think this is my last slide. Next slide, I would like to hand over to Nuria for the vaccine supply considerations.
Thanks, Amina. Hi, everyone. Good morning, good afternoon. My name is Nuria Cardayagueta-Mitch. I'm a contracts specialist in UNICEF Supply Division in the Vaccine Center, and I work on contracting and procurement activities for DTP-containing vaccines. So overall, working very closely with suppliers to ensure that there are enough stocks of the different vaccines to cover the overall demand, and together with the rest of the partners, I'm aiming for an overall healthy market. Today, I'm going to present this, which is the last section of this presentation, on vaccine supply considerations. Next slide, please. The first slide is a general slide on supply considerations, and then I will go more in detail describing the market for each of the specific vaccines. So when we talk about supply considerations in the context of the DTP booster program, it's very important to flag that the markets for some of these vaccines are very much interrelated. As for DTP, Penta, and Hexa, they share the DTP bulk. Therefore, it's very important for the market, for countries to define which boosters are going to be implemented, the specific timelines, but also what is going to be the vaccine of choice. And this is going to help to allow managing the supply of these interdependent markets. You can see in the slide the vaccines that are available for procurement through UNICEF in line with WHO recommendations. So for the first booster in the second year of life, if countries decide to procure through UNICEF, then DTP, pentavalent, and hexavalent vaccines are available with the whole cell pertussis presentations. For the booster number 2 during childhood, both DTP with the whole cell and TB vaccines are available. And for the third booster during adolescence, the TB vaccine would be the only vaccine that can be chosen as it's the vaccine that is age appropriate. So as I was saying, defining the forecast for each vaccine is key to be able to communicate this long-term forecast to suppliers, and at the end ensure enough supply availability through the DTP program and also through the regular supplies. So UNICEF and partners will be managing the demand generation process under both the hexavalent and the DTP booster programs to, as I said, adequately balance the demand and supply at the same time as ensuring a long-term health of the markets. Next slide, please. Then going specifically on each of the vaccine markets, the first slide is on the DTP vaccine. As we have seen before, this is a vaccine that can be a choice for the first and for the second boosters. Right now, there are 3 manufacturers in the market that have a WHO pre-qualified vaccine with a whole cell pertussis presentation, and there is ample capacity in the market for both the bulk on the DTP and generally for DTP-containing vaccines production. What it's important to understand here is that these 3 manufacturers, they also have WHO pre-qualified pentavalent vaccine, and one of them also has a hexavalent vaccine. So basically, suppliers need to make decisions on how much of the DTP bulk is used to fill DTP vaccine and how much should be reserved for filling pentavalent or hexavalent vaccine. And that's why this long-term visibility that I was mentioning and the demand scenarios, it's very important. Then UNICEF passes this information for suppliers for them to make the appropriate business decisions. On the DTP specifically, UNICEF has 2 LTAs with WHO pre-qualified manufacturers, and it's supplied on a 10-dose presentation. What's also special for the DTP vaccine compared with the other vaccines that I'm going to cover later is that the demand for DTP vaccine traditionally has been relatively low through UNICEF. On average, we have been procuring only around 7 million doses annually. And because the procurement from UNICEF has been in the past this relatively low, significant changes in demand would require some time for the market to adapt. So as I said, the bulk is there. It's more whether we inform suppliers that there will be an increase of DTP demand as a standalone for them to react appropriately. Next slide, please. Next slide is on pentavalent vaccine. Pentavalent vaccine can be a vaccine of choice for the first booster during the second year of life. There are currently 5 manufacturers that have WHO pre-qualified vaccines with a whole cell presentation, and UNICEF has LTAs with 4 of these suppliers. We are supplying pentavalent vaccine both in 1 and 10 dose presentation. The demand through UNICEF for pentavalent vaccine is relatively high. The average procurement has been between 150 to 175 million doses. Actually, in 2024, we would be higher than that because of the demand through catch-up, and also probably at the start of 2025. And then going forward, the demand for penta vaccine will be assessed in consideration of the evolution of other interacting markets. For example, the demand for hexavalent vaccine and potentially some countries switching from penta to hexa, and also the demand through the DTP booster programs that we are covering today. So UNICEF will be complementing the current awards for penta vaccine for 2026 and 2027, considering the interdependencies of the markets that I was mentioning. In principle, there is adequate availability and production capacity in the pentavalent market to accommodate changes in demand in the context of the DTP booster program. Next slide, please. Next slide is on hexavalent vaccine. Hexa vaccine can be a vaccine of choice for the first booster as well, for the second year of life booster. Right now, there is one manufacturer that has a WHO pre-qualified vaccine with a wholesale pertussis presentation, and UNICEF has established 2 LTAs with this manufacturer. One LTA is for Gavi-eligible countries for attend those presentation, and then another LTA for middle-income countries and Gavi countries that are not eligible for hexavalent support on the 1 and the 10 dose presentation. And as I mentioned for penta, additional awards will need to be made for hexa, also for supply in 26 and 27. And the demand to be awarded will be defined considering once again the interdependencies with penta and hexa markets and the DTP vaccine booster program. So therefore, once again, the importance of having a clear understanding on the requirements that will come through the DTP and the hexa programs, so the suppliers can make the right decisions based on a clear long-term forecast. For hexavalent vaccine, the supply availability will be gradual, and in the early years, it will be driven mainly by the materialization of the demand. Next slide, please. So the last vaccine that can be chosen in the context of the DTP booster program is the TB vaccine with a small d. This is a vaccine that could be selected for the second booster, for the childhood booster, and it's also the only vaccine of choice in the case of countries deciding to implement the adolescent booster, the third booster. There are 5 manufacturers that have a WHO pre-qualified TB vaccine with ample overall production capacity. Right now, UNICEF has established LTAs with 4 of these suppliers, and they offer the vaccine in both a 10-dose and a 20-dose presentation. Again, this is a vaccine that UNICEF procures in relatively high volumes. We procure between 130 to 140 million doses on average yearly. So overall, I can also say that the same for the other vaccines. There is adequate supply availability, there is production capacity in the market to accommodate any changes in the TB demand that would arise in the context of the DTP booster program. So this is my last slide. If I would summarize this section, I just want to once again highlight the interdependencies in the supply market for DTP, for penta, and for hexa due to the sharing of the DTP bulk, and flag therefore the importance for countries to identify which boosters will be implemented and which would be the vaccine of choice for each of the boosters. This information would, of course, be passed accordingly to the suppliers for them to allow making the right decisions in terms of bulk production and in terms of bulk allocation, and overall helping to ensure timely availability of vaccines for the program and also continuous health of the market for all the DTP containing vaccines. This is the end of my section. I'll pass over to Stephanie for one last summary slide. Thanks.
Thank you, Nuria. So that was a lot of information that we went through. Luckily, we do still have time for Q&A and discussion, as I'm seeing there's already so much activity in the chat and in the Q&A box. But we just wanted to come back to sort of one grounding slide with the key takeaways. So reiterating, to maintain long-term protection against diphtheria, tetanus, and pertussis, we do need booster doses beyond the 3 primary infant series. WHO recommends 3 diphtheria and 3 tetanus and at least 1 pertussis booster during childhood and adolescence, given as combination vaccines. As of December 2023, Gavi-eligible countries can now apply for support to introduce any of these 3 recommended DTP-containing boosters. As we indicated, this doesn't have to be in order necessarily. It might make sense for a program to start with the TD booster in adolescents, potentially aligned with HPV or at another point in the adolescent health touch point, and then move from there, or they can start with the 2IL booster. Any booster is helpful because as the waning immunity seroprotection goes down, the boosters are needed to bring it back up again. So this is why the recommended schedule is spaced out in the way that it is. And I want to refer everybody back to the schematic that we showed earlier in this presentation around on the tetanus slide in particular, because it shows how your seroprotection levels are up here after the primary series, and as they start to decline, the spacing of the boosters is recommended in a way that brings those protection levels back up again before they decline to non-protective levels. And then finally, with the 6th dose, so the 3rd booster, there's evidence that that will be sustained into adulthood. So countries can apply for support for 1, 2, or all 3 boosters. Everyone provides benefit. As our supply division colleagues took us through, the vaccine options that are available through UNICEF could be the DTP standalone, or the pentavalent option, or the hexavalent option, and the TD vaccines for the adolescent booster or the childhood booster. And each booster provides opportunities for integration and program alignment with its delivery platform. So Nicholas talked about the opportunities at the 2IL touchpoint, particularly on the school entry one, where this actually might be a way for programs to initiate that contact with the education system and use that as leverage to expand on school-based immunization or school-linked vaccination. And of course, the HPV adolescent one is an obvious one that's really quite a low-hanging fruit. Not enough countries are leveraging. So hopefully that provides a good recap, and the links to the funding guidelines as well as all 3 position papers are here in the chat. So with that, I want to open the floor for questions. So we've been trying our best to answer the questions in the chat along the way. So if you did put a question in there, please take a look and see if there's a response. We'll also speak to some of them live as well, because we do have some time and then everyone can benefit from the answer. But I also want to let people raise their hand if they want to come in with either a question or a comment. It's great also to see that there are a lot of countries represented here that do have booster programs already. And so if you're working in a country that actually does have a booster or all 3 boosters, and you want to share some insight on how long that's been in the program for, how well it's been received, if it's a recent introduction, anything that can help us sort of share experiences, because there are also a lot of countries represented on the call today that don't yet have these in their programs and might be considering introductions now that Gavi support is available to us. So I'll see if there's any hands raised. Okay, we do have one. Dauda, I'm sorry if I'm not pronouncing that right. Simpara, please. I'm going to unmute you and you can come on in.
Thank you very much, dear Stephanie. I also would like to thank everyone here. I had a question. As you know, in my country, we haven't introduced booster doses in our programs yet. So what I would like to know, with a Pentavax, what could be the consequences if we use the pentavalent vaccine for all 3 doses, all 3 booster doses in children? as I said, we haven't introduced that vaccine yet. So what would happen if we use the pentavalent booster for all 3 boosters? Would it cause any issue? And my second question is regarding if a country wants to introduce this booster dose in its programmation. How do we play catch up with adolescents who did not receive the first dose and the second dose? So that's my second question. For adolescents who didn't receive the first and second booster doses. So also regarding schedule, if you have any kind of schedule for playing catch up with adolescents, it would help me to answer the last question I have. So the last question I have, which is regarding what does it mean DTWP, WPTD? What does it mean? Thank you very much.
Thank you so much for those questions. I also didn't catch which country you're from. I don't know if you said that at the beginning, sorry, but I didn't catch which country, but
I come from Mali, but now I'm working in Congo Brazzaville.
Okay, great. So thank you for all 3 questions. Maybe I'll do a first pass and then hand it over to any of my co-panelists, Nicholas, or others to expand on the responses. So on your first question regarding Penta, so as you know, Penta contains 5 antigens, and actually it's only 3 of them that we really need to be addressing with these extra boosters. So any additional doses of Penta are going to be giving some extra vaccines. Now, normally there's not really harm in giving some extra doses of antigens, which is why we say, okay, you could use a Penta for the second year of life booster, because we recognize that this might be very programmatically easier for a lot of countries since they already have it in their supply chain and they're already giving it. And 1 additional dose of hepatitis or 1 additional dose of Hib is not going to do any harm, so why not? It also provides an opportunity for catch-up. If children have missed earlier doses, then they'll at least be getting those antigens. However, once you get above 5 years, Hib isn't recommended anymore by WHO for vaccination of over 5 years. And the diphtheria component in the Penta vaccine is the pediatric diphtheria dose, which is not recommended for children over 7. So it isn't really possible to give Penta for all 3 boosters, because once you're getting into the adolescent, it's no longer recommended to be giving those other antigens and the pediatric formulation of diphtheria. So this is why T with the little d, or a Tdap, or a combination that it involves the correct formulation for that age range is recommended for that booster. The second year of life provides more flexibility because you're still dealing with a very small child. And so it's why we say that the second dose could be given as a Penta or Hexa, the first booster and even the second booster, because when you're in that 4 to 7 year range, we know a lot of countries have that booster at 5 years old or even 6 years old, where you still have some flexibility with the formulation. So that's my response on Penta. The catch-up is an interesting question, and I think that the booster schedule is a really perfect example of how catch-up vaccination schedules can become really complicated as immunization program schedules expand into the life course. Because as you can see from the booster recommendation, the formulations change at age ranges, and also the number of doses that you need change depending on how many vaccines you've gotten in infancy versus if you're starting later. So I know this is very complicated, and this is why I actually just put a link in the chat directly to the Protecting All Against Tetanus guidance document that was published by WHO and UNICEF a few years ago, because it really addresses a lot of these questions that are coming up in the chat around vaccination of adults, and the slide that Nicholas showed earlier around the number of doses of tetanus that are actually needed in antenatal care decreases depending on how many you got in childhood, because you really only need a total of 5 doses if you start vaccination later. 6 doses are needed if you're starting in infancy with the primary series. And so when countries are designing their catch-up schedules, it really becomes important to have different catch-up schedules based on the age that the individual is presenting at the health center. So we have examples from a lot of countries of catch-up schedules that have, one catch-up schedule for children under 2 that, and how to catch up on the primary series and childhood vaccines. And then another catch-up schedule for children 7 to 18 that are coming to a health center and they're missing vaccines. Because it is complicated and it does require a lot of guidance for health workers on how to understand how to establish the correct intervals and which vaccines to use depending on the ages. So unfortunately, it's not easy to just come up with a standard schedule that WHO can publish that says, this is the way you do catch up, because it really depends on the national immunization schedule, which vaccines you have, which ages you're normally giving them at, and then therefore which ages to space the catch up vaccinations. And this is why WHO produces recommendations based on the position papers that include age ranges. And then the country, with the guidance of the NITAG and other partners in country, can develop an appropriate schedule for their setting. So I know that doesn't really directly answer your question, but I hope that if you look at the resource shared and it's available in English and French, that might help you. And of course, happy to follow up afterwards offline with more specifics for the Congo-Brazza situation or whatever other specific country you're working on. The last thing I'll say is the AP and WP, that refers to wholesale pertussis or acellular pertussis. So en français, je pense que c'est germe entière or cellulaire entière et acellulaire. So it's CE and CA en français. But in English, it's a little W or a little A, and it just refers to the type of pertussis component in the vaccine. Does anyone else want to expand on that answer? Nicholas, did you want to add anything else?
I think you said most, Stephanie, but maybe just to add that a hexavalent vaccine with acellular pertussis has been around for more than 20 years, and many high-income countries and upper middle-income countries have been using this vaccine for this time. But over time, it has shown that the acellular pertussis component is not as effective in the protection against pertussis as the whole cell component. And this is why WHO recommends countries to continue with the whole cell pertussis. And it's not until this year, actually, or late last year, that a WHO pre-qualified hexavalent vaccine with the whole cell pertussis component became available to countries. So it is Gavi doesn't provide vaccine support for the acellular hexavalent vaccine, but it does provide support for the whole cell pertussis vaccine. It is also the whole cell hexavalent vaccine is reducing the number of injections you need to give to children, but it's also, of course, a bit more expensive than the combination of pentavalent and standalone IPV doses. So countries have to consider whether they want to pay that premium cost for reducing the number of doses and having a more streamlined schedule. Over.
Thank you, Nicholas.
Actually, I wanted to add, if I can take 30 seconds more, I also wanted to add, since we were talking about all 3 booster doses, I wanted to emphasize the need of protecting boys and men, because as I said, 4 out of 5 tetanus cases are men today, outside of the neonatal period where we still have some newborn children with tetanus. And tetanus still has a very high case fatality rate. Around half of all cases of tetanus in low-income countries lead to death, actually. Although with the appropriate medical care, it's possible to survive tetanus, but the fatality rate is very high. And boys and men are more exposed to the tetanus bacterium, both through their work and also in many countries because of traditional, and in some countries, traditional circumcision, and also in some countries circumcision to reduce the risk of HIV transmission. Over.
Thank you. That's a great point to really, really emphasize. It gets lost a lot of times, and with all the, important focus on MNTE and the campaigns for women of reproductive age, the boys and the men are really getting missed out in a lot of cases. And of course, they're still very susceptible, as we all are. Tetanus is everywhere, and if you're not protected, then it's quite dangerous. So another gender dimension to bring into the conversation. I see a question in the chat around Hexa supply and whether we should go for IPv2 introductions or Hexa. The issue, of course, is the cost of Hexa, which we know is significant. So maybe our supply division colleagues can respond to that. Is there any info on market shaping where we can ask the government to go for Hexa rather than IPv2?
Yes, I can answer that, Stephanie. So there are a few questions on Hexa. One question that I saw in the chat was regarding the pricing. I have answered that. So just to share that all prices for Hexa and the rest of the vaccines that are procured through UNICEF are public. So I have shared the link to the UNICEF site where the prices for all vaccines are described. So you can just go there and check for Hexa and also Penta, DTP, and the others. Regarding the availability for Hexa vaccine, yes, as Nicolas was explaining, we have the first WHO pre-qualified supplier for the wholesale pertussis Hexa vaccine. The contract is in place with the supplier, and UNICEF has started to procure from them. And yes, there is availability of hexavalent vaccine in the market to cover the current demand. Regarding the IPv2 introductions and the issue of the cost, that's of course up to the countries. We recognize that with the current price of the wholesale Hexa vaccine, the price is higher of the than the 3 doses of Penta plus the 2 doses of IPV. However, this is a start market, and of course, as it has happened with the pentavalent vaccine and many other vaccines, we expect that the price will reduce as the market develops. And there are other benefits for the Hexa vaccine, such as the reduction of cost on the devices, the reduction of the shots, the points of contact, and the preference from parents for less shots on children. So that's, of course, up to countries to decide whether they switch from Penta to Hexa. But the supply is there, so just to reassure that it's available now if countries decide to switch on the primary series or on the first booster.
Thank you, Nuria. Maybe let's go to another hand now. I see Akshaya Mishra. Do you want to come in with your question?
Can you hear me?
Yes, we can hear you.
Yeah. I don't know what is the time there, but here it is very early morning, 2 a.m. I am Dr. Akshay Mishra calling from Samoa. Thanks, Nicholas, for highlighting that. I really wanted to attend this session because it was really important for the country where I'm working now. Somewhat, I mean, the population is very small, but the country has been having all the 3 boosters since more than 8-9 years, if I remember correctly, the history of the vaccination in the country. And the coverage has been quite good also in terms of the school vaccination, which goes on for the TD1 and TD2, and also the DPT first booster, which we give that also is close to, I can say, 70%. But my concern is that there are cases of pertussis in this part of the world. I mean, especially if you see New Zealand, there are in last 4 weeks there are almost 200 cases of pertussis that have been reported. And for the first time in my last 5 years stay in Samoa, I have seen today the first case of pertussis has been reported in a child of 7 weeks of age. So 7 weeks of age, the child has not been vaccinated. We don't know the mother's vaccination status. There is a growing fear because of the high number of cases of pertussis in and around. So the country wanted to implement the Tdap vaccine for the pregnant women. Now the question arises: this vaccine is not available for procurement. So I don't know what is the answer to that actually. So if the country wants to implement that, which is already a WHO recommended vaccine for pregnant women, and there are like perceived threat, and which is quite evident also that we are getting cases of pertussis in the children who cannot be vaccinated also, and the vaccine is not available. So what is the answer for that?
This is a very good point that you raise, and as you're correct that WHO doesn't have a firm recommendation on this. We have what you could call a permissive recommendation. People refer to this as different things, where in WHO position papers, there are certain things that say countries should do X, Y, Z, or some countries may consider doing X, Y, Z. There's definitely evidence, as you say, that vaccination of pregnant women does have an effective it's an effective strategy for protecting the infants. But Tdap is expensive, and as you say, it's not available for procurement through the UNICEF mechanism. There is also some evidence that shows that vaccination of pregnant women with Tdap, the maternal antibodies that are passed along have an impact on the seroconversion of the infants following routine immunization. So there's lots of factors to consider. And I just wanted to let you know and everybody know that the WHO position paper on pertussis vaccination has not been updated since 2015. So it's definitely due for a revision, and there will be a SAGE working group on pertussis formed the beginning of next year. So we will be looking at all of this data around pertussis, around Tdap, around vaccination of pregnant women and other special populations, risk groups, even adolescents, and updating the vaccine position paper accordingly. Many countries do procure Tdap on their own and provide it to pregnant women. We have a lot of countries that have that in their schedule, but you're right, it is an expensive vaccine, so it's not as accessible for everybody. And this is part of the work that's going on in the background to see how we can bring the costs down, like with all of our market shaping activities and things like this. But unfortunately, I don't have a quick solution to that for you, other than to say that this is an area of work that's ongoing. I don't know if any of my other colleagues online have anything particular to add around the Tdap piece on vaccination and pregnancy, or the availability of a vaccine through the UNICEF mechanism anytime soon.
Unfortunately, I have no idea whether it will be available through UNICEF or not, and I don't know if Nuria does.
Yeah, no, this is not a vaccine that is available at this point or in the near future, and one of the reasons is indeed the very, very high cost that we are seeing. Also, the suppliers that are procuring or selling these vaccines, they haven't been in the past interested to supply through UNICEF because they have their own private markets for their cellular vaccines. So this is neither a market that we have seen interest from suppliers to explore.
But thank you for raising this, because indeed this is a problem, and it's going to be, continue to be a problem for countries that rely on procurement through these mechanisms when we don't have access to this vaccine in this market. So a flag also to pass that along to our colleagues that are working on advocacy with manufacturers and market shaping activities. So we'll take that concern.
Thank you.
I saw a question in the chat from Ravisha, I think, asking whether they should introduce Hexa or the second dose of IPV. And I think there are many things to consider there. One is, of course, whether your country is eligible for Gavi support, which is, I think, a strong reason to consider Hexa, because you get that financial support to introduce a new vaccine. But it's also important to remember that WHO recommends that all countries must introduce a second dose of IPV because it protects against paralytic poliomyelitis. Also, when you have circulating vaccine-derived poliovirus transmission. So you shouldn't delay the decision to introduce second dose of IPV because you are considering or thinking about Hexa. Vaccine prices tend to reduce over time when volumes go up and more use them, and more countries buy them, but you can't predict that with any certainty. But I mean, the assumption is that the price of hexavalent vaccine will fall over time. So that's not a very definitive answer, but it's important to consider that IPV, introducing the second dose of IPV is important. Maybe the countries that have the most financial opportunities to introduce hexavalent vaccine are probably the Gavi supported countries.
Stephanie, I just wanted to add on what Nicholas mentioned on the opportunities of Hexa. Unfortunately, we are discussing Hexa and the DTP boosters, which is just one option of the DTP boosters in second year of life. Countries have the opportunity to also introduce DTP, plain DTP or Penta, which are basically cheaper than Hexa. But for Hexa, the advantage that it comes with is that it is combined with IPV, which is operationally very conducive for the EPI program. But that notwithstanding, countries also need to know that the IPV dose is fully subsidized by Gavi. So there is an opportunity that they can take in going with IPV2 standalone instead of combining with Hexa to ensure they get the protection, children get the protection early enough as required by the WHO recommendation. But that said, many countries have also not introduced IPV2, and it's something of concern. I think that needs to be flagged, that as we look at how to reduce the Hexa cost, this opportunity should be taken by countries to introduce IPV2 as early as possible to ensure the immunity gap is bridged for the polio, contributing to the polio eradication initiative, as it were. And we've shared the answers in the chat, also provided the links that countries can get more information on to be able to utilize in their decision making. Stop here. Back to you, Stephanie.
Great, thank you. I'm glad that you pointed that out around the options at the second year of life, because I did see there were a couple of questions around, is there a standalone DTP option? Yes, of course there is. And so you reinforced that message. Maybe I don't see any more hands, but maybe we can look at some of the questions that have been answered in the chat, just for the benefit of everyone on the call in case they haven't been following that question box. So Belladora asked how to determine the status of TT vaccination coverage if the recording and reporting system is not good yet during the ANC screening. And so Nicholas, thank you. Nicholas responded that, of course, the principle is better safe than sorry. Absolutely. If the pregnant woman doesn't have documentation of the previous doses, then, of course, proceeding with vaccination is the safer and recommended option. There's no risk with associated risk with receiving too many doses, but obviously there's a huge obvious risk of not being protected against TT. So this kind of underscores, and as Nicholas pointed out at this section of the presentation, that this really links into the importance of good record keeping and strengthening individual record keeping, which we know is a challenge. It's a challenge for childhood immunization programs with home-based record availability and retention, declining with age, and even sometimes as early as the first and second year of life, we still see a lot of times where home-based records aren't at their optimal level of coverage, and the same thing goes for ANC screening. And so strengthening that record keeping so that both the individual and the healthcare provider has good data of how many doses received, that will just contribute to the ability to reduce over-vaccination. And so it's definitely like the longer term goal as countries strengthen their coverage of the 6-dose primary plus boosters series, eventually, along with strengthened and data recording systems, will be able to reduce their ANC vaccination. But of course, the better safe than sorry principle absolutely always applies, as does for childhood vaccines. If you can't verify, better to revaccinate and ensure that that child or that woman or that anyone is protected as they deserve to be. Imran had a good question, a good comment around the reaching out of school children. Nicholas, maybe you want to actually just elaborate on this one out loud, because it is really a problem, of course, not only for the second booster or the third booster, but with HPV as well. We know that it is sometimes a challenge to reach out of school. And so this is something that we all should be thinking about and working with, other sectors to strengthen the ability to reach these individuals. So maybe Nicholas, you want to just read this one out loud so that everyone has the benefit of that response.
Or maybe I just talk to it because it's obviously Imran is correct that the children who do not attend school should also be protected and receive the same vaccination as children who do attend school. But reaching children in the 4 to 7 year age group who are not in school is much more challenging, of course, than reaching children who attend school. Imran provided a figure about 250 million children being out of primary school in the world. I'm not sure that the figure is that high in reality, because the global birth code is around 130 million children, and if you take that 6 times, it means that every third child would be out of school, and even higher than that in the low-income countries, because most out-of-school children are in low-income countries. But nevertheless, it is an important thing to think about. For HPV, we know that your countries regularly achieve higher coverage with HPV for girls when they organize the vaccination in schools, around schools, either give the actual injection in schools or organize so that girls are recruited in school and giving appointments to have the vaccine in a health facility. So using the school platform as a way of delivering vaccine is effective. As you saw in the slides, very few countries, and particularly very few countries in the lower middle income and low income country group, have a DTP booster dose for that age group, for that school entry age group. So I think you have to start somewhere, and for that reason, my recommendation would be to start with a school entry checkup or immunization status, and providing opportunities for catch-up vaccination of other vaccines that children are missing, and maybe then particularly for measles vaccine. But at the same time, think about how to reach the out-of-school children through social protection programs, through community health workers who should be able to identify and pick up the most vulnerable children who are out of school and make sure that they have a contact with immunization services. Over.
Thank you so much, Nicholas, for emphasizing these important points. So we only have 2 minutes left, and it doesn't look like there's any more hands. I think we've managed to cover off all the questions in the chat, but if your question hasn't been answered for some reason, or you're not fully satisfied with the answer provided, then do feel free to reach out to us offline and we can continue this discussion. I also want to say that this is just the first of these webinars that we will hopefully be having over the coming months. We'd like to do a webinar that's more specifically targeted to NITAG audiences. We know that in particular, this is a tricky one for NITAGs and for anyone involved in prioritization within countries, because you have 3 booster doses to consider, 3 different antigens with their own burden of disease, their own waning immunity patterns, their own epidemiology. And so it's not a straightforward program by any means. So we want to make sure that we're providing all of the relevant support tools and information needed for countries to be able to look at this carefully. So we will be hosting additional webinars, and again, particularly targeting NITAG audiences. So for anybody on this call today, if there's additional information that you'd like to see covered that hasn't been covered in today's presentation, or any areas that you think we should elaborate on further, or that you would want to see covered in future webinars, please let us know. I absolutely want to make sure that everyone's needs are addressed. So reach out, please. I'll put my email address in the chat, but I think you can all find me. And we'll share this information and recording out afterwards, absolutely. But we can expand on this and include additional content in future ones if there is specific needs for additional information. Anything else to add, my panelists, Nicholas?
I'd like to thank you, everyone, for the attention. And I want to say, I see a message in the chat from Carlota Martinho about Guinea-Bissau. I have not introduced the second dose of IPV, so that's important that they build it, of course. But she mentions that this is in the National Immunization Strategy document that covers 2024 to 28. I'm really happy to see someone bringing up the NIS here, because this is where countries should express their plans for vaccine introductions. It doesn't mean that you have to switch from Penta plus IPV to Hexa next year. You can make a plan of doing that in 2028 when you are more aware what the cost will be, and you may have to introduce more urgent vaccine in that. But the use of this document, the National Immunization Strategy, is very valuable for planning the optimization and prioritization of introduction of vaccines. Thank you.
Thank you. And with that, we have to close because our lovely interpreters will be leaving us. So a huge thank you to Emily, our interpreter, to all of my co-panelists, Nicholas, Amina, Nuria, and everyone that helped contribute to the background preparation of this webinar, Alex at TechNet, Rachel for screen sharing, and everyone online for their active participation and engagement. Thank you so much for waking up early or staying up late. We'll see you all soon. Bye, everyone.
Thank you so much.
Thank you. Bye.
Bye, everyone. Thanks.
Okay, bye-bye.